Hey everybody, welcome. It is Friday, the day before the start of Thanksgiving week. As we discussed in class, we won't be meeting next week, so I wanted to put together a screencast so that once we come back the following week, we'll be ready to go for lab. So this week we are continuing our discussion of upper extremity, making our way down to the elbow forearm. So really all we have left is this lesson and spine, and that'll pretty much be it. So I've had a chance to go through your exams. I've heard from a couple of students that they're having trouble seeing the feedback. I'm not sure why. The settings are exactly the same as exam 1. So if you're having trouble, just drop by and I can show you. You can take time to look at the exam and hopefully answer any questions that you have. With that said, let's get started. All right, so we're going to take a look at some surgical techniques with respect to primarily the elbow, and then take a look at elbow rehab design and a number of common conditions and what we can do for rehab's sake. All right, now we've talked about the role of dynamic stabilizers in the past at the shoulder, at the knee. Dynamic stability of the elbow includes all the muscles that cross the joint, and in particular we're talking about brachialis, triceps brachii, and anconeus. These muscles, when they contract, all provide a compressive force. That is in contrast to the joint capsule, to the ulnar and radial collateral ligaments that provide static restraints. So what can oftentimes happen here is initially the patient may start with shoulder pain, and over time they change their mechanics, a thrower particularly we're talking here, and now all of a sudden we've exposed their elbow to potential trauma. So in the case of Tommy John, this is one of the more high profile elbow surgeries, an ulnar collateral reconstruction using a graft from the palmaris longus usually. This was initially performed by Dr. Jobe of Curlin and Jobe fame, and during that time there was some debate as to whether or not the pronator needed to be involved in the ulnar nerve transposed. What oftentimes happens, one of the common issues with Tommy John surgery is whether or not they've had an ulnar nerve transposition, because without it, there's a fairly high potential for continued ulnar nerve symptoms, numbness, tingling out into the fifth digit and half the fourth. But in the case of transposition, that nerve is actually buried within the muscle tissue anterior to the medial epicondyle. Okay, so generally speaking, in classic Tommy John surgery, that graft gets harvested from ipsilateral palmaris longus. There are other grafts that can be used. If that's not a possibility, not every patient has bilateral palmaris longus, then that contralateral palmaris longus can sometimes be used. Other sites include the gracilis, plantaris, toe extensor tendons, just depending on the patient. This was a minor league player. You can see he's got a tattoo there. Pain equals wisdom over his Tommy John surgical incision. Lots of times our athletes that present with this may have dealt with elbow tenderness or soreness for quite some time, and in trying to throw through it, they actually make the condition much worse. So with the Jobe procedure, the pronator is split and the ulnar nerve gets transposed, so we move it from its normal anatomical position here anterior to the medial epicondyle. Another procedure, Altchek is another orthopedic surgeon who utilizes what's called a docking procedure. And he splits the flexor carpi ulnaris but does not transpose that ulnar nerve. Basically, try to prevent tension from occurring. This is considered a safe zone, but it's not maybe as invasive as the traditional Jobe procedure. So here you can see where that flexor carpi ulnaris is split. thereby preventing compression. Okay, so here you see where the graft itself is sutured together. Okay, so if we're dealing with a patient who is recovering from Tommy John surgery, that first week they're going to be splinted, limited movement here. After the first week, they're able to move between 45 degrees of extension, 90 degrees of flexion, and then gradually we're going to return to full range of motion within the next 5 weeks. Okay, key here is we don't want any valgus load across the elbow during this phase of recovery. And I say strengthening here. So we have to be real cautious in the exercise that we prescribe, because if they are introducing a valgus load, then we're exposing that graft to tensile forces that it's not ready for. Okay, so this is an example of a Tommy John rehabilitation protocol sheet. So phase 1, immediate post-operative phase, 0 to 3 weeks. We see splinted, 90 degrees of elbow flexion. We can do wrist active flexion extension, active range of motion. Gripping exercises, putty squeezes. In lab, we'll take a look at the different tools we'll use. TheraPutty, TheraBars, the Power Web grippers, the independent grippers. All those can be good as long as we're not introducing valgus load. Okay, biceps isometrics, we still want to maintain nerve supply there, but we're trying to avoid aggressive elbow strengthening at this point because we don't have the range. Okay, you notice how every week that range of motion grows from that 45 to 90 we talked about already. So by week 2 we're already in this particular protocol 30 to 100, by week 3 15 to 110. Okay, and we're going to gradually increase that 5 degrees extension, 10 degrees of flexion per week. If everything goes according to schedule, that's about how they should return to normal motion. Okay, then we enter phase 2, our intermediate phase. We're going to gradually increase to pretty much full range of motion here and begin to restore and improve strength. Okay, cross fiber friction would certainly be appropriate here. Definitely scar massage. We haven't really talked much about scar massage in here, but in order to prevent soft tissue adhesions, even just freehand scar massage without using tools would be beneficial. Week 4, notice we begin some light resistance exercises with shoulder rehabilitation exercises. Notice we're going to avoid external rotation because of the likelihood of encountering a valgus load. Okay, so if I'm externally rotating against a wall isometrically or against resistance, I am introducing potential valgus load there. We'll probably have them braced functionally, continue to progress their shoulder, progress their elbow. So by week 6, looking pretty good, but notice we're still not throwing yet. Okay, so our advanced strengthening, it's going to be somewhere around month 3. We're going to start to head towards sport specific, just like we've talked about with all of our phases. Notice eccentrics don't start until week 9 because of the risk of soreness and also the tensile force involved here. Also, we can start some light plyo, so our weighted ball drills, things like that might be beneficial here. Light sport activities by week 12, but they're not throwing. Okay, so we don't actually start throwing until week 14. So this is why this is such a big deal for our throwing athletes, because notice they're 3+ months before they can even begin to think about throwing a baseball again, let alone actually competing. So here we see somewhere around week 22 to 26 return to competitive throwing. Lots of times in baseball this would be you've heard the term rehabilitation starts, where maybe a big league pitcher undergoes surgery, they get sent down so that they can face some live batters, but it's not at the risk of losing games. So lots of times at the minor league level, I know when I was in El Paso, Randy Johnson got sent down to the El Paso team. They were a Diamondbacks affiliate at the time, and he actually started a game there in El Paso. Just pitched a couple of innings, got to face some live hitters in a real live game situation. Good for him psychologically. Now that I think about it, I think it was Curt Schilling, not Randy Johnson. Either way, one of them got a rehab start in El Paso and then promptly went back to Phoenix, where they returned to play. So our interval throwing program, I've given you this sample here. I said I'd give you one. This would be something that early on we might stop at, at the 90-foot phase. Okay, so oftentimes this example is number of throws, but other programs that I've seen are actually based on duration, so they won't spend as much time at the longer distances. Okay, so in this program it's stepwise, and we don't progress to the next step until they're able to complete the prior step without any problems. Okay, so when we said our patient would initiate interval throwing program at week 14, they're probably going to be just right here, step 1, 45 feet. They're going to just do nice, easy warm-up tosses, probably, normal game of catch, 15, 20 feet apart. 25 throws at 45 feet, half the distance of the baseline. Rest for 15 minutes, do it again, another 25 throws, see how they feel. Okay, and that's the end of step 1. Now there are multiple versions of interval throwing programs out there. I would encourage you to get with Tyler and Francis. They probably have an example of what Brian uses. I don't have his current one. This is actually from a minor league team that I worked with, and the orthopedist that I worked with there. So this sample shows you, before they actually start to throw off the mound, they get all the way through step 14. So if they progress, a step a day, then here's our 2-week interval throwing program. If they encounter soreness, a lot of pain along the way, then we might stay at that particular step for a day or two. So it's not guaranteed to be 2 weeks long. It's in all likelihood going to be a little bit longer than that. Okay, so when we look at non-surgical elbow management, actually now that I think about this, I'm going to go ahead and stop this here just to make these a little bit more manageable. So that'll be the end of this video, and we'll pick up here for the next one. So I'll see you in just a second.